We are doing the Grand Roundup live. This
Let's
week, we're
go.
thinking about MA plan, devoted healthcare, leaving some breadcrumbs for us, which we'll kind of get into. Product liability in the AI era, and Kevin revisiting his 1L year, and states getting the first tranche of money for implementing work requirements. So, and if we have time at the end, we'll do a quick whip around of the public and private markets. But to get us started, Kevin, you've been spending some time on Devoted's job board recently. Are you thinking about making a career change?
I wouldn't go that far, but I do find jobs boards to be one of the more interesting things to peruse if you're looking to learn about what's going on with a company. If they are hiring, you can see where their strategy is pointing, right? So Devoted on their jobs page has, I think, 47 jobs this morning. One of them is for a primary care operations role, which I thought was really interesting, in part because it includes the data point that Devoted has roughly 700 clinicians in their medical group. Devoted, like the integrated payer provider models, has their insurance arm, Medicare Advantage, focused today, and they've got their medical group, which is a clinical organization. So the clinical organization apparently has 700 clinicians, and the job posting noted that they delivered 200,000 encounters last year. Both seem like big numbers. Devoted had, I think, 207,000 MA members last year. But if I do the math on 200,000 encounters and 700 clinicians, it equates to roughly, I think it's 1.1 encounters per working day, like the 255 working days of the year, which isn't the most efficient organization today, but perhaps is indicative of where Devoted is going over time from a clinical perspective. And if you look at the 47 jobs, I think 28 of them are clinical in nature. Like Devoted is pretty clearly going after building a virtual care delivery model with centers of excellence around chronic conditions like heart failure. And I think that's a really interesting play, right?
Yeah, I really appreciate when you do the math like this. We should note that Devoted is gearing up for some pretty massive growth. They had, I think, the highest as a percentage growth. The other thing I'll note about Devoted is that they also had the highest growth in terms of special needs plans out of all of the plans. And so I don't think there's any world where your NPs are doing like one visit a day and that is the right amount of visits. But I will say that you get paid more for a special needs plan, and often because the special needs plans people need a lot of extra attention. And so the ratios are not going to look exactly like what they would look like for a traditional MA population, but they're definitely going to go a lot higher than one visit per clinician per day.
Yeah, I would assume they're scaling up. The other thing I was curious about is, okay, are they not all full-time roles, right? Do they have contractors that they're just lumping into that 700? Is it not all employed docs? When I go through LinkedIn, they have a lot of what appear to be full-time employed NPs. And so I don't know how that 700 breaks down. Perhaps it's not everybody working 40 hours a week type work. Either way, there's a lot of folks on that clinical team, which, to your point, I think is indicative of what they are presumably scaling up for. Now, even if so I think their 2026 MA membership is growing to 466,000 lives. If you double the number of encounters, that's 2.2 encounters a day. Like there's still a lot of capacity in that system, it would seem. And so I'll be fascinated to see where it heads.
I think it's interesting to talk about productivity in this context. So you and I were chatting. We've both worked. You worked for a health system. I worked for a medical group. I think the typical, say fully paneled NP is seeing, I don't know, roughly 20 patients a day in a primary care sort of normal traditional setting. That's very different from what they are currently doing today. The other thing that this job posting talks about is 5,000 AI agents, and I don't really know it feels like everyone's talking about how many AI agents they have. Kevin, I don't know how many AI agents you have working on the newsletter, but
I don't honestly, Martin. I don't It sounds like a really impressive number. I see that, and my first reaction is, okay, this is cool. Devoted is using a lot of AI in care delivery. And then I step back and think about it for a second. I'm like, what does I don't understand how to compute what 5,000 AI agents mean. Beyond my expectation is that it should make an organization like that more efficient. And going back to your point on if a typical MP sees 20 patients a day, and if Devoted even scaling up is having its MPs see 2 to 3 patients a day, I think this fits in our ongoing theme of we see the impact of AI everywhere except productivity statistics, right?
Yeah.
It just doesn't compute to me.
I think that you can kind of bear and bull case this sort of thing and say, okay, well, we're about to hit those productivity increases. If that was the case, I don't think you would be, if you were expecting that, I don't think you would be going long on so many clinical assets, so many NPs. If you were expecting just around the corner your
Yeah.
clinical agents to be able to
Yeah.
be doing the lion's share of the work.
Which I think is the reality of the space these days. And by the way, I think it's a realistic approach. I don't think that's a critical statement on Devoted. The fact that it's building up its clinical base, right? We were talking about this a little bit last week with Talkspace and UHS. Like the asset that UHS is acquiring in that scenario is the 6,000 therapists that are in Talkspace's network. I think those clinicians are important today. They're going to be important in the future. And yes, the 5,000 AI agents might make them incrementally more efficient in managing their jobs, but I don't think it is, we're at zero marginal cost of care delivery where one person is treating all of Devoted's patient population anytime soon, What I
You
think
did a fun. Oh yeah. No, you
I
go.
was going to say, to me, that bull bear case point is an interesting one. And thinking about Devoted's bull bear case going forward, it's like, so the bear case, I think, would center around it's focused on Medicare Advantage today. They're growing really quickly in Medicare Advantage. We've seen what happens with Medicare Advantage plans when they grow quickly. Presumably, they're going to be hemorrhaging cash on that side of the business. If they do have 700 care clinicians and are only doing 200,000 patients a year, presumably they're hemorrhaging cash in the medical group side of the business. Those two things do not equate to a successful business long term. That is, I think, the thrust of a bear case scenario here. Bull case scenario, I actually think is a really fascinating conversation around Devoted moving towards becoming a virtual national Kaiser-like model. That's what I mused a little bit about in the end of the newsletter, where you can imagine Devoted building these 700 clinicians in its medical group, building virtual centers of excellence in its medical group around complex chronic conditions, managing heart failure, so on and so forth, and extending beyond just being a MA plan to other insurance types and having control of the full healthcare dollar and helping patients navigate that healthcare dollar within the construct of its various plan offerings. I actually think that would be a really interesting model to see play out in today's kind of macro environment. There are shades of access when I hear that, right? This idea of how do you provide care using apps, AI, et cetera, in a scalable way to the chronic population that's kind of that rising risk category. I'm like, I actually think that would be really cool to see play out. And I'm curious to see if we see that narrative come more to the forefront here for Devoted over the coming months and years.
I think an interesting. So I agree. Like that's a great hypothesis, and I think one more piece of evidence there is if you look at the participation of their last financing round, Morgan Health participated. Not there are some MA plans that are involved in employer health, but Morgan Health's mandate is focused on actually employed, not retirees who are, who are involved. And so
Yep.
that was a bit of a head scratcher for you and I. And I think this helps close the loop on what is going on there, which is this isn't just a MA story. And I've shared this with you offline, but everyone I have, all of my friends who have had Kaiser insurance in California and have left California talk to me about how much they miss Kaiser. It is the only insurance company that I have ever heard, bracketing Surest perhaps, where people have actually like come up and told me, "Oh, I love this insurance company so much." And so it feels to me strategically like if you are a large integrated payer provider delivery group and you sort of look across the market and you see a ton of those, it is a race to see who can be the for-profit Kaiser. And
Mhm.
that's the strategy that makes, I think, the most sense to be pursuing in this moment and for the next 5 to 10 years. And Devoted, I was not on my bingo card, I think, before this weekend. And I think that they're someone to watch when it comes to that strategic thesis.
For sure. I mean, they are coming at it a very different way than the more traditional orgs are thinking about the space, right? Even Kaiser is approaching its attempt to go national by buying up various systems across the country, which makes sense from a traditional lens. But if you're thinking about rethinking the cost structure fundamentally, again, this is where it feels very access like to me. It's like, yeah, what if you could just build virtual centers of excellence that become your primary touch point? There's then a whole bunch of interesting strategic questions of, do you ever build in person assets? And at some point, does it make sense where you have density in markets to open a devoted clinic? I would presume that they are playing a 10, 20, 30, 40-year game. And if they are successful 20 years from now, that might be the case. They're not going to talk about it today because they're not that far in the journey, but you can see how that could play out and could be a really cool offering over time.
Switching gears a little bit. For those of us whose LSAT scores were a little bit softer than yours, what is a tort? And what does it have to do with AI?
So as I shared with you, I live in fear that my law school professor is going to pop out somewhere and start critiquing me on my
And Kevin, in
misinterpretations
fact,
of
we
what
have
I
a
learned
special
growing up.
guest.
Yes.
Just kidding.
So tort class, torts are wrongs, right? There's various types of wrongs that you go through in tort class, and it was a formative experience for me from an intellectual perspective. One of the series of cases that we talked about in torts was product liability coming out of the Industrial Revolution into the early 1900s, when a judge, Judge Cardozo, decided a case called McPherson versus Buick that became landmark case in product liability law. And the whole concept was, at least as I understand it, my interpretation today and what I wrote about in the newsletter was, um, the Industrial Revolution changed how you produce and consume goods, right? We went from one of one exchanges to companies that could now mass produce goods using factories, so on and so forth. When that happened, this required companies and us societally to think about liability differently, because you no longer tended to have a contract with the between the seller and the buyer in the same way you always had historically. So the Buick versus McPherson case, McPherson was an individual who bought a Buick Runabout. Runabout, I think was the car name, 1909 car. I put a picture on LinkedIn. It's actually a really nice looking car. I'm like, I want one of
I
those in
drive the
my.
heck out of that.
Yeah, that would be fun as long as the wheel works, Martin. And this was the issue of the case. Buick sold the car to a dealer, and the dealer sold it to McPherson. The car had a defective wheel that Buick arguably should have noticed when it was manufacturing the car. I think Buick bought the wheel part from another manufacturer. Buick should have inspected it. And McPherson got hurt when the wheel broke after he purchased the car and was suing Buick for negligence. Buick said, we don't have privity of contract with McPherson, which was kind of the legal philosophy of the day, which was you need to have a direct contract with the person. But because the dealer was in between, the thinking was Buick couldn't be sued. McPherson came along and said, no, Buick has a duty in selling to anybody, whether or not they have a contract. And this became the legal theory of the day moving forward. It was, to me, fascinating because it was the culmination of a series of court cases where judges were trying to work through, what does product liability look like in this world where you can mass produce goods. And Cardozo came along and said, here it is, right? This is what this new regulatory schema looks like going forward. And there are so many parallels between the change that the Industrial Revolution brought on in the relationship between buyers and sellers, and what it feels like we're going through in this AI-centric revolution, if you will, around the relationship between in healthcare between producers and consumers of healthcare goods, which are doctors and patients, right? And so I talked a little bit about Doctronic in the newsletter, which I think is a fascinating case to me, and almost how overblown I think the reaction is to Doctronic on a couple levels. So there was a red team that came out and hacked into Doctronic system, right, Martin? And there were parts of the hack that were, I think, somewhat amusing. They made the bot speak back to it in Creole. There were parts that were more concerning, right? There's, it turned into Walter White for a period of time. It was spewing misinformation. But at the end of the day, it was a red team that hacked into the system, and it was only their prompts that caused it to respond this way. It's not like if you went into Doctronic system, Martin, and asked it questions, it'd be responding in that way. And it brings up all these interesting questions of liability and who's responsible. Is it the patient and the consumer who is going into an AI chat and typing these things in and injecting fake regulatory documents to make it think differently? I don't know that I actually think Doctronic is in the wrong in a scenario like that, but it's definitely a gray area of how much caution should they be exercising? How hard should it be to access systems, et cetera? Either way,
One
really
thing
interesting
I'll
example of all of that. Go ahead.
one thing I'll quickly interject on that is that Doctronic in Utah. So there's kind of two branches of the
For
Doctronic
sure.
story. So there's this
Yeah.
interesting red team. We got these hackers, and it's an interesting story. We also have Doctronic in the Utah sandbox doing refills. I
Right.
don't know if it is unclear, and it seems unlikely that the hackers got into the Utah sandbox refill thing. Right? These are, I think, two separate systems. At least that's what the person you interviewed from Doctronic said.
Yeah.
The second thing I'll say is number two is that they have doctors reviewing the refills, and so it is unlikely that someone could actually do this for themselves. They couldn't get Walter White sending their prescriptions. But this is the tension between innovation, insurance, and
For sure.
and and liability.
Yeah.
We have malpractice insurance for Doctronic in Utah, like a doctor would have. We have this innovative thing that can save lots of time and money. And we have this red team saying there's the possibility that someone could do something untoward or harmful. And they could do wrongs. There could be tortious behavior. And so that to me is the sort of philosophical question that we're left with here, which is these systems have some give in them. We have to sort of trade them off with one another. We'd never have any innovation if there were unlimited liability for folks like Doctronic. But we also don't want the prescribing system in Utah to be able to be easily hacked and for people to be able to get Schedule 1 narcotics.
For sure.
2
I
narcotics,
mean, that
one.
is clearly that would be bad, right? Like we don't want that. But I think this is going to take time for it to resolve. My kind of overarching reaction in the newsletter is regulatory and legal frameworks, they follow innovation, right? In part because you need for a judge like Cardozo to come along, who now has buildings across the country named after him as kind of preeminent legal scholar from the early 1900s. You need the prior 30 years of cases that are like, well, why did that get decided that way? Or this happened and that seems like it was wrong. So that you can have that history of cases to adjust to. And I think we're in that messy middle period here, right? Where I don't think Doctronic to me was all that concerning. Perhaps the only part that actually concerned me is the lack of response from Doctronic's support team to MindGuard's flagging the issue for them. Like I'd be interested to hear Doctronic talk through what happened there. What I do think is a much more interesting case is Prenuvo and the lawsuit Prenuvo had over the scan where they missed what apparently appears to be a fairly visible issue that an individual had. They ended up having a stroke, and they are now suing Doctronic and the doctor who reviewed the results. But it's like, there's a human in the loop there, but the human perhaps acted in a cursory way that we didn't look at all. Like, who's ultimately going to be liable for that sort of stuff? Is it the Pronuvo AI forward system? Because they certainly, like, you go on the website and it's all about how AI is changing the game. Is it the doc who is rushed and perhaps not in a great setting to review all the results? I think those are going to be interesting questions for us to grapple with over the coming years.
Going back to cars for a moment, a interesting thing about safety features is that they tend to make, so we as human beings are sort of bad at calculating like how much safer a safety feature makes us. And so there's some funny examples of this. Bikers who wear helmets, like cyclists who wear helmets, are riskier than cyclists who, like, more risks than cyclists who don't wear helmets. If a car is coming at you, it really doesn't matter. It matters a lot if you're wearing a helmet or not, but it doesn't matter as much as the sort of change in risky behavior. Same thing with the sort of advanced safety features on cars. So you have lane assist, you have, and humans, you become reliant on these things and you trust them, but they're not perfect either. There's all of these other things. And so I also, I do worry about, in the Pronuvo case, where we have AI saying, okay, AI is really good. Disclaimer, please double check our work. And then folks being like, but the AI is really good.
Mm-hmm.
It's like wearing a helmet and taking riskier decisions while cycling.
For sure.
The other sort of, I think, timely piece of this conversation is around access. So you talked a little bit about this in the newsletter. I was wondering if you could expand a bit on that.
Yeah, we were talking in the community, was it last week, about the health affairs article on access and the critique of some of the parts of access models. But one of the parts of the critique being essentially that the payments to primary care providers are going to allow the shifting of liability from the virtual health providers, the remote monitoring platforms, et cetera, onto primary care docs for what happens to patients when primary care is reviewing the data once a year. And I think that's a valid concern that folks are voicing and thinking through. And I understand why they would have that concern and kind of the current construct of liability of today's world. And I think it's indicative of what's going to have to change over the coming years, right? Like it's just not going to work that way for a primary care doc to be liable for what an AI thing says, if that is what is actually providing care. And there's a whole bunch of implications of that. But that is where I find that really interesting personally.
My sympathy is with the insurance underwriters who have to figure out how to write a malpractice insurance contract in this case. Like,
Yeah,
I don't know.
I don't either. I mean, there's going to be, I would imagine, some court cases that will need to decide this over the coming years, and that's part of, it's until there's more clarity on that stuff. I think it's probably going to be a hard space.
Yeah.
Should we go on to MA? Our favorite ongoing
subject.
theme? Let's do it.
So what costs more, MA or traditional Medicare? Kevin, 30 seconds. Give me your best guess.
I don't know, Martin. MedPAC tells me that MA costs more for the federal government than fee-for-service Medicare would. 14% higher in 2026, as a matter of fact.
So MedPAC's annual report came out, and it came out last week, Thursday night, and I think if you spent all of your time reading it between now and then, you still might have not gotten all the way through it. It is a lengthy annual report. But yeah.
400 pages? It's huge.
MedPAC has this house view that other people disagree with. So what is MedPAC? MedPAC is a think tank, basically, that advises Congress on Medicare. Their mandate is to advise Congress, and they employ like 16 or 20 people, and they have this job where they just get to think about Medicare all day, and it's a cool job. There's something similar for Medicaid. It's called MacPAC. And so yeah, you talked a little bit about the MedPAC report. 14% higher. The drivers of that are favorable selection and coding. By favorable selection, what they're saying is MA patients are healthier than traditional Medicare patients. That's a pretty debatable question. And there's not a satisfying answer for this. On the one end of the ledger, you have hospice patients who are all traditional Medicare. And so, yeah, those are like the highest acuity, most expensive. And so that's true. End stage renal disease, it's like a 60-40 split between traditional Medicare and Medicare Advantage. Those are also expensive patients. So, but there's also a sort of tendency for people who are lower income to end up on MA because $0 premiums is like, what a deal. So yeah, I think that there is a lot of pushback always to MedPAC's numbers. The Healthcare Affordability Lab at Yale published a piece, and it was this sort of comprehensive. So this is a new lab, and they've got an all-star team. They published a piece on Medicare and Medicare Advantage, and their summary was basically MA does spend less than traditional Medicare, even accounting for favorable selection on a person by person basis due to care management. That makes intuitive sense to me. You give someone a capitated rate, and the insurance company will manage it down. But it costs the government more based on the generous benefits. So that is your supplemental benefits like dental, vision, hearing, and then also the gym memberships and whatnot, coding practices and risk adjustment. So that's kind of the tension that we have here. We don't know which one costs more or less, Medicare or Medicare Advantage, but there's kind of good arguments to be made on both sides, and people are sort of continuing to argue about that. What I think is interesting in this moment is that there's just been a ton of bad news for Medicare Advantage plans. It's like a constant treating of MA plans like a piñata lately. And you have Elevance, who's like submitting their risk adjustment scores based on on USB drives and getting banned or barred from enrolling MA enrollees until they fix it. You have a bunch of settlements for under False Claims Act stuff. Aetna is the most recent one. You have congressional members of Congress hauling insurance execs and in front of them and admonishing them. You have the Wall Street Journal basically saying you're all criminals and thieves. It kind of feels like the bipartisan consensus on Medicare Advantage is cracking a little bit. What's your read of the situation, Kevin? I led the witness a little bit there.
For sure. I mean, there certainly is this narrative has been happening for a bit now, right? Where you even hear Klump talking about it at the Better Medicare Alliance annual meeting the other week, and on various public forums. There's this question of, is the government being a good taxpayer of federal dollars in the Medicare Advantage program? And that seems like a reasonable question to be asking oneself when thinking about these funding dollars. Back to your kind of the point on the theory of the case, I have yet to see a better explanation than the 2019 Health Affairs article that the Blue Cross and North Carolina team did at the time that had this. It was talking about why advanced primary care models aren't scaling beyond Medicare Advantage. And it had this great chart that suggested that the reason why it's taking off in Medicare Advantage is because it's a win-win-win for providers, patients, and payers. All three of those parties do really well. The one party who does not do well is the government, because they are the one footing the bill for that program. And I think we've seen that play out now over the last 6 years since that article was written, where I think it was 2019, maybe it was 2020. It was around then. I think that's what we're seeing play out. And I think we are now grappling with how do we set the program on a new trajectory in a way that we can theoretically support it, but also in a fiscally responsible way. And so I'm curious. I'm curious to see how that plays out. You mused a little bit on this creative destruction concept in your newsletter last week.
Yeah. Well, a couple of weeks ago, I was at a bachelor party in Stockholm, and
That's the beginning of every good
it,
story.
it was cold. And so one of the things we did is go to the Nobel Museum, and the Nobel Prize for Economics this year was to a couple of economists who basically created a quantitative expression of creative destruction. So it's been on my mind, the
Okay.
idea of what creative destruction means. And I think when we think about Medicare Advantage, we're in a creative destruction moment. You have a lot of very large businesses that have been engineered around Medicare Advantage looking a certain way. And the way that that looks is you have a sort of unfair advantage compared to traditional Medicare because you get the supplemental benefits. You've got the risk adjustment, which just creates a ton of money for you to do great stuff with. And everyone's kind of happy, except
Mhm.
for the taxpayers. And that is not the view of the CMS, but it was also just never really sustainable. There was always going to be, the music was going to stop at some point.
Mhm.
And if you think about what a MA plan needs to look like in a new environment, the Yale Healthcare Affordability Lab talks about how, if it was just HMOs and you pared back supplemental benefits were a bit more modest, it would Medicare Advantage would be the clear winner in terms of, versus original Medicare. So I think, and you and I have been talking and, listening to Alignment Health and Clover a lot recently, but I think that we're entering an era where Alignment and Clover are the model. That is the sort of what the new status quo looks like. And the Humanas of the world are going to either have to get their cost structure down and figure out a way to be more like these smaller players, or they're going to gradually lose market share to Alignment. Like I think this is an ultimately healthy expression of the market, and what we're seeing is that there are going to be winners and losers, and the losers are going to be those who have relied on the financial engineering, the risk adjustment stuff, and whose their cost structure is just structurally higher than the Alignment Healths of the world. So that's kind of my view, but I'm curious to get your reaction on that.
I zero disagreement on my side of the world. Beyond, the plans you cited are still pretty small. And I think the question is how can those models scale, right? Like that is the unanswered question as of yet. Certainly, I interviewed John Kao, Alignment CEO, the other week, and he talked about how he thinks it'll actually be easier to scale alignment beyond California because there aren't IPAs in the same way there are in California outside of California, and that'll actually allow them to drive incremental savings because that's just another layer on top in the California market. Plausible. I think it'll be interesting to watch that play out over the coming years. I also think it's worth noting, we just talked about how devoted essentially our hypothesis is that they're moving towards being a healthcare system that has an MA plan. And it's again a very similar narrative. And I think you're right. Like we hear a lot about how MA is trying to get back to its original intent of what it was trying to accomplish. And while I wasn't reading the original intent of MA back when it was first coming to fruition, but as I understand it, heavy focus on care management, managed care principles to manage care while driving down costs. And it seems like a logical theory of the case that we should be moving back in this direction of more care management-y type principles.
I think that question is the right one: is can Alignment and Clover scale?
Mhm.
Is are there sort of diminishing returns on their ability to keep their cost structure low? I think that is a totally fair question. The other thing I'll say is it is not necessarily the case that we are at the right size for the Medicare Advantage market, and that it could get a lot smaller in order for it to be profitable and deliver savings to the government. And so the alignment growth and the devoted growth and the Clover growth might be in some ways at the expense of Humana, but I do think that the pie will, at least in the near term, shrink a lot more. I think that, I'm not calling the top quite yet on MA enrollment, but if we proceed in this policy trajectory where the pie is getting smaller, then I do think that the MA enrollment's going to have to go down. That's my view.
I will be fascinated to see how that one goes. I would not have 10 minutes ago, if you had asked me what is MA enrollment going to be in 2030, I would have said higher than today. I'll be curious to see how that trends over time.
There's an interesting gentleman's bet for us to formulate here.
Let's do it.
I want to talk a little bit about the states. So the first tranche of work requirement money got delivered to the states. So this is the money the federal government, through the One Big Beautiful Bill Act, allocated to states to implement work requirements. It's basically a little bit less than $2 million per state plus the District of Columbia, and that is not all of the money that they're getting. They also get 90% federal match for new system builds and 75% federal match for ongoing costs. So there's a lot of federal government money going into these new work requirements.
Okay.
A case study for you is in the great state of Georgia. And Georgia has had something that looks pretty close to the work requirements that are getting rolled out federally or nationally. And they did this via an 1115 waiver. It's a Medicaid innovation waiver. It allows states to try stuff out. So they've been rolling out the work requirements over the last couple of years. And I pulled up a GAO report, the Government Accountability Office, to get a look at what they've spent so far. And as of 2025, so between 2021 and 2025, they've spent $6.7 million of their own money on this, plus $47.4 million of the federal government's money on implementing these work requirements. The idea of an 1115 waiver is it's supposed to either improve quality or reduce costs, but it has to reduce costs. So it'd be great if you could keep the cost same or improve quality or reduce costs. And that's a lot of money. So that's $54.2 million total on implementing work requirements. That's purely administrative spend. I mean, that is money. I don't know if Georgia uses Deloitte, but it is essentially a payment from the federal government and the state to a contractor like Deloitte to update the technology system, do outreach, handle the sort of administrative complexity of adjudicating work requirements. And the GAO said basically like, hey, this is a crazy amount of money to spend on administrative requirements. A nice thing for CMS and for these 1115 waivers is that historically they have not had to look at the administrative costs. They only have to look at the program costs for whether they save money or not. And I think even baking in for administrative costs, enrollment has been so much lower. It's been about 50% of what Georgia was expecting. And so they've definitely saved money, but they saved money because they've covered a lot fewer people. This is part of the story that we're watching with the One Big Beautiful Bill Act is, are you going to be able to roll out work requirements in a way that doesn't lead to reduced enrollment? No. I think the answer to that is just you will not be able to do that. Georgia is a case study. Hopefully people can learn from Georgia. But the way that this stuff saves money is by covering fewer people, even if they would be eligible.
I looked up while you were talking the KFF article that talks about Deloitte's contracts with Medicaid agencies in various states. Georgia is a Deloitte contract. Deloitte makes over $500 million in the state of Georgia. nice contract to have.
I'd take it. I mean, I don't know much about CMS systems, but I'd learn for $500 million.
Fair.
That's the HTN promise right there. Let's take a look at public markets for a second. So starting on the plan side of the house, a couple weeks ago, there was about maybe a month and a half ago, there was the Medicare Advanced Rate Notice. The proposed rate was a little bit lower than people were expecting. Is that how you would characterize it, Kevin?
A lot lower. Yeah.
Like 9 basis points, basically, right?
Yes.
0.09% increase from 2026 to 2027.
Yes. There's been a lot of consternation since. Everybody submitted their comments to CMS about what they think rate notice should be. And it's interesting. So we'll hear what in early April, right? What final rate notice is. But companies are now going to, there's a few bank conferences last week where companies gave updates to the investor community. And they're all starting to talk a little bit more about where they think this final rate notice is going to come in. Two of the more interesting updates: Alignment, which expects a solid opportunity for growth in 2027 because of what we were just talking about with its model dynamics, and how its model works relative to the broader market. They had a really interesting dialogue, one about skin substitutes, but also some recent Wakely data around this delinking of chart reviews, which is one of the key things that kind of took a couple points off rate, which is that Wakely suggested some plans could see a 6% rate cut from delinking chart reviews, which is a very large rate cut. And in a broader context of, we've heard some regional plans already struggling financially. In my state of Minnesota, we've seen UCare have serious issues, and that causes huge problems for the market. We've seen reports out that suggest a lot of regional plans don't have the financial wherewithal to make it through the next 18 months. If some of those regional plans are the ones facing that 6% cut, that seems like a huge issue. So that's one thing to keep an eye on. The other thing to keep an eye on was they got into this conversation around a miscalculation on skin substitutes and how they actually think that will probably be a 1.5 to 2% lift for rates in the final notice, which is a good guy, going from that 0.09% to 1.5 to 2 right there. KO noted after saying that he expects final notice could get to 4% on the whole, given those couple dynamics, which is above the 2 to 3% that most folks seem to be expecting it to come in at. Clover noted it's like the range of 2 to 5% at the high end. So it seems like everybody's expecting the floor to be 2% as the final rate notice, potentially something higher than that. And back to this conversation we had around broader Medicare market strategies and what companies are up to, Clover made the fascinating point that they would actually welcome an almost flat rate increase because from their point of view, it'll highlight the strength of their model relative to the market, which to me is if I'm CMS and I am hearing that and I am wanting to encourage competition and stability, I am going, that is an interesting comment.
And KO said something similar
for sure
on an earnings call.
Yep.
I think that it's very nice of KO to say, like, it doesn't affect me, but it could be 4%. It's like all upside for him. He gets to, he's the, I think the chair of AHIP's, like the AHIP Medicare, Medicaid duals and commercial thing. So he's being, a good coalition partner there in his advocacy, but he's also said, like, I don't care for my business. Clover's saying the same thing. I can't wait. I can't wait to see. We will likely have an emergency pod when the rate notice drops because it's going to be interesting to see. That skin substitutes piece is amazing. That's like finding some serious change in the cushion that allows you to bring the rate notice up a couple percentage points while not having to change the underlying. You don't have to go find more money, which is nice.
For sure. Point 2 I found interesting. ACA membership tracking. I know you've been following this one closely. Centene gave an update that their decline is tracking in line with expectations. Their book's down, I think, 40%. while they expect the industry to be tracking in the high teens to mid 30% range. It sounds like you've seen it tracking towards the lower end of that, which mirrors what Elevance suggested in their conversation, which was that early member effectuation data is tracking with previous years, which, if that's true, seems like it would imply less attrition than perhaps the industry has been expecting to come in kind of this first quarter of 2026.
The one piece that I'll add to this sort of mosaic we have of all of these different numbers until we get the effectuation rates, which won't be till early summer, is Oz said he threw out a guess at around 19 million. I don't know if that was finger in the wind. I don't know if he's, this is based on effectuation rates that he's seeing, but he put it at about 17 to 19%. And so that would definitely be on the lower end of what folks were expecting.
For sure.
Centene set out to shrink their book, and they were successful. They were, prioritizing margin over growth, and that's kind of how we got to that 40%, which is a really eye-popping number.
Totally. The other interesting tidbit that came up in HCA's conversation was that they were saying they might actually expect disenrollments to continue into 2027, which is the first time I've heard that. Like, I always thought of this as kind of a confined to Q1 2026 exercise, but they made the comment almost in passing that as families are grappling with costs of healthcare, they might expect to see this continue into 2027, which I thought would be interesting to keep an eye on.
Talk to me about what you heard from our friends over at Humana.
Yeah. Again, this is one of the more interesting MA narratives at the moment. Humana more clearly stated at their investor conversation this week that they will be adjusting benefits as they adjust to the overall rate market in MA in 2027. Logically, they have to, right? Like, I don't think it's a surprise to anybody to hear them say that. It is part of operating as an MA plan. But what is interesting to me is it puts this concept of lifetime value to the test. Humana has been talking about lifetime value for the last couple earnings calls in a way that I don't think I've ever heard an MA plan talk about before. I mean, I know they all think about it, but it's never been kind of on the forefront of earnings call language as Humana has made it recently. And what's interesting is from year 1 to year 2, they talked about one of the key drivers of lifetime value and margin improvement is the reduction in payments to brokers. So in year 1, acquisition costs for a new member are roughly $1,000, which, if you're a plan making $12,000 a year on an MA member, that's a big part of your margin that's going to acquisition costs right there. And so going from year 1 to year 2, Humana said on the call that $1,000 goes roughly in half, which goes down to $500. I think in the Slack community this week, one of our members was talking about how another MA plan leader was describing similar financial mechanics there for broker payments and acquisition costs from year 1 to year 2, which is where a lot of the value resides in reducing churn for those MA plans. So if you think about, if you're churning out 5% of your members versus 20% of your members year over year, that's margin point of difference for your overall profitability as a plan, which is kind of wild to me. So it'll be interesting to watch how they are able to maintain their membership from 26 to 27. And their bet essentially sounds like they are going to adjust benefits in a thoughtful enough way that they are not going to churn membership such that they can still benefit from the margin improvement on those members, which is like 4% margin improvement on that slice of the membership. So it's going to be an important part of their narrative to watch. We'll keep an eye on it as the year goes, I suppose.
Shifting gears a little bit to the provider side of the world, I think it's funny when Tenet says they're not worried about site-neutral payments. Like, of course, you have a large ambulatory surgery center. Of course, you're not worried about site-neutral payments. That's just a tailwind to a large part of a large and profitable part of your business.
For sure. It was interesting though, because the way I actually heard the question, that is how I have always framed site-neutral payments as a tailwind for ASCs. But the question almost came in questioning the other side of it, which is, when site neutral payments come, are you still going to be differentiated from other facilities? And that's where they said, we're not worried about what's to come. And the framing of the answer was, it's not going to come in a really meaningful way where kind of the complex surgery volume is going to shift to ASCs as a result of site neutral payments. That's going to reside in a hospital. What's going to be in the site neutral payments legislation, if that comes, is going to be the lower complexity stuff that is already moving that direction. So they're like, nothing burger, kind of, is the way I interpreted their statement, which was interesting to hear on both sides, right? Because that is the way I've always framed the ASC conversation in my head, is exactly what you just said.
It's a good story, and I feel like you can argue it both ways. We're going to talk about surgery partners in a second. It's kind of funny to look at how the market is thinking about a pure ASC play, kind of, and these hospital systems like Tenet that also have a ambulatory surgery center. Before we get to that, though, I want to quickly touch on Agilon, and they talked about high costs. One of our favorite subjects in is these extreme outliers. Can you give us a quick update on what Agilon was talking about at this conference?
Yeah. So on the whole, Agilon is in middle of business turnaround in 2025 to 2026, right? Right sizing their value-based book, how they approach that, getting to profitability. They are on the journey. One of the most interesting comments they made briefly, and they talked about this a little bit on their earnings call too, is they had to revise their assumption for trend in 2025, the full year trend assumption, from 5% to 6.5%, which 1.5% is a big deal, right? And that was driven entirely by, I think it was 3 high-cost members, who all had million-dollar medical expenses in the quarter, and Agilon expects a handful of those people a year, and the fact that they got it in 1 quarter made them adjust upwards their medical trend adjustment. One of those patients they called out was a gene therapy patient who was over $1 million in spend. But to me, it is a good reminder of how much a very small N of members can throw off insurance pricing models pretty quickly. And I think that's unless you've been in insurance before and actually seen how 2 people with, $1 million, even when you manage 100,000 people in your entire book of business, can throw everything off. It's kind of a wild concept, right? So it was interesting to hear them go into that level of detail on those couple of members in the quarter.
On the public market side, I want to end with surgery partners. The thing that I heard about surgery partners this week, and I saw the announcement on Friday evening, I believe, was that they added a new member to the board of directors. You had talked a little bit in the community, I think, about some activist shareholder stuff. What's going on over at Surgery Partners such that they needed to add a new member of a new member to the board?
Yeah, activist investor was not thrilled with management, right? I think they see opportunity on the table, wanted them to get out of some facilities, focus purely on being ASC operator, viewing that as the opportunity, suggesting that they are leaving things on the table. So they've got work to do. I don't know if the new board member was related to that or not, but clearly there's some shareholders who think there's value to be unlocked inside of Surgery Partners on the whole. I thought it was the update on the bank conversation was fascinating in that they talked about, like, here are the specific markets and here's where underperformance is actually happening. And one of them, they talked about how they were surprised at the share of Medicare Advantage business that they got in that market, because essentially they were the only player in town where volume could be sent to. And not surprisingly, Medicare Advantage rates don't look quite as great as commercial rates. And so this was a hit to profitability for Surgery Partners in that local market. And they're like, we've now got to dig out of that hole. There were a couple other markets they talked about. One was rural market where they had issues with providers and getting providers into the model and so on and so forth. But like, these are the kinds of issues these organizations face and are trying to manage through, So I thought it was an interesting example of that.
Switching over to the private market, I think you and I have both worked for startups that have raised seed rounds. Did your startup raise a seed round of $1.03 billion?
No.
Okay. Mine neither. So I was a little shocked when I saw that they're called AMI Labs is calling a seed round. AMI Labs, it's a world model. I don't know what that means, but they are a startup that is sort of joined together at the hip with Nabla, the medical AI scribe.
Yep.
So that was wild. What are we doing?
Yeah. I we should have them on sometime to talk to explain this to us because I think both of our heads explode seeing stuff like this. Like I don't have any context for what this means. Nabla's CEO is going over and becoming the CEO of AMI Labs. Is that a good thing for Nabla? Is that a headwind for Nabla? I don't know. On the whole, it seems like it's probably a good thing in this AI centric world that you have an exclusive partnership with a new lab that is worth $4.5 billion at seed financing. But like, I don't know. I feel like I need to go back to school to understand what this stuff means because it is way over my head. Do you think any differently on it?
No, many questions, not a lot of answers from the press release. Would love to have them on. I do want to talk about a company called Nitra, which raised
Mhm.
a round or announced a round rather. They sort of announced all of their financing up until this point. It was a combination of equity, Series A, Series B, plus some debt and a warehouse facility. I had the chance to chat with the CEO, Tim Wong. He also founded a company called Fiscal Note, which
Hmm.
is a DC sort of staple. Really nice guy. We had a great chat. Basically, they launched this company and it was a business card for medical practices. So you think, you own your practice, you need a credit card, that's where you're ordering your, nitrile gloves, and if you're a buy and bill provider, you're putting there's a lot of expenses and you can put a lot
Yeah.
of them on a card, and so this is a credit card for physician practices. Interesting little business. And then if you think about all of that transaction data, it's kind of useful as understanding what the practice is spending money on. So they're getting paid, like Visa or like a bank that would partner with Visa or MasterCard on the swipe fees, interchange
Hmm.
fees. And so that's partially how they're making their money. This is free to provider groups. And then the other part of it is they've gone out to all of the supply companies, the Cardinals and McKessons of the world, and have built a little platform where they can sell not a little platform, it's actually quite large, where they can sell their stuff to these practices. And they have AI agents who are going out and saying, they also talked about how many AI agents they have working on this. But if you think about it, okay, I need to order nitrile gloves on a regular basis. After a certain amount of times of ordering that, probably the AI can guess right when I'm about to run out, and you can, automate that, and that's like a nice thing if you're trying to run a practice. So it's a cool business. They're
Yeah.
growing like weeds, just crazy growth year over year because it's free for the provider groups. They're making all of their money on swipe
Yeah.
fees in this internal marketplace. I think it's an interesting model.
So does the
Less
marketplace
healthcare.
become like a GPO for these practice? Like,
Yeah, that's what it
yeah,
seems like.
interesting.
And Tim made it clear that they are getting price parity, like they're getting the best price
Yeah.
because it's a marketplace.
Yeah.
I was thinking about this though, and I was like, I'm sure you could even charge for the like you could it wouldn't even need to be perfect price parity. If I'm thinking about I'm a physician entrepreneur, the main thing I want is predictability and
Hmm.
this off my plate. And so
For sure.
it's nice that it's there's price parity, but I, I have to imagine doctors who are running their own practices are also have a pretty high willingness to pay for convenience.
Yeah. That's interesting.
Any other private market rounds you want to touch on in the last minute?
I thought Translucent was a pretty cool round to see. They raised 27 million bucks. Google Ventures led it. They've got a Chicago-centric roster of clients: Northwestern Medicine, Dooley Health and Care, focused on, as I think of it, like an AI financial analyst for hospitals and helping hospitals better manage their financials in real time so that they can drive margin improvements and stay in operations, which to me is a really cool, tangible use case of AI. And I appreciated how straightforward that was. So I thought that was a really interesting round. Malama, which raised what, 9.2 million bucks. I always think doula models are fascinating. I think maternity outcomes in this country would be a lot better if we could somehow figure out how to support more doula-led models in care delivery. So it was fun to see that
breaking
one.
news, you'll be happy to know Kayaba, which is now called Nadia Care, raised a $12 million round this morning as well.
There we go. Hey, more of it. Love to see it. So I was excited to see those two.
Yeah. So that brings us to the top of the hour. Thanks so much for tuning in, everyone. And Kevin, thanks for your time today. And we'll be back next week with more from the Grand Roundup.
Best of luck with the tornado watch today, Martin.
Thank you. Bye.
See ya.